Welcome back to the CSP Elite Baseball Development Podcast. I'm your host, Eric Cressey, and this is episode 193. We are long overdue for doing another listener Q&A, so I've actually got some inquiries that came in via email from people who have listened to the podcast and have some questions about a variety of sports medicine and baseball performance-related topics. So I'm going to hit those today, and hopefully there's a little bit of something for everyone as we work our way through this. Overuse injuries have emerged as one of the biggest threats to players at every level of competition. As an example, at the professional level, ulnar collateral ligament injuries at the elbow alone sideline pitchers for an average of over 17 months. That's a ton of lost development and a threat to lengthy careers. Just as concerningly, though, for youth players, overuse is the predominant mechanism of injury. So what can be done? Obviously, we need to train athletes to be prepared for all the stresses the game throws at them. However, the other side of the equation, recovery, often doesn't get the attention it deserves. Healthy, recovered arms mean you can stay in the game and give your best on the field, and that's where MarkPro comes in. MarkPro is a cutting-edge recovery tool that provides all the benefits of active recovery, but without the extra effort, muscular fatigue, or stress to tendons and joints. Players can use MarkPro as long as needed for exceptional recovery between training sessions or after games. We'll often send MarkPro units back with athletes to their hotels or even have them use them on team flights. Both easy to use and portable, MarkPro is a powerful tool that allows recovery anywhere, anytime. Use it while relaxing at home, on the road, or during tournaments. On a personal note, I was originally a naysayer when it came to MarkPro. However, longtime Cressey sports performance athlete Corey Kluber turned me on to it. He adopted MarkPro into his post-pitching recovery approach, and it was an integral part of him going out and throwing 200 innings year after year. This led me to experiment with it myself and with more of our athletes, and the feedback was consistently outstanding. Now, just a few years later, you'll see it in every major league organization as part of the routines of some of the most accomplished baseball players on the planet. If you're looking for the same results enjoyed by these athletes, visit markpro.com and use the coupon code Cressey at checkout for an exclusive discount. Again, that's markpro.com, markpro.com, and use the coupon code Cressey, Cressey, at checkout for an exclusive discount. For our first question, I've got an inquiry from a college pitcher. He said, I'm a college pitcher and I've been dealing with some mild shoulder discomfort after pitching for a while. And with my season wrapping up, I decided to get it checked out with our team doctor. The doctor said that my MRI was pretty normal for a pitcher my age and I just had a little inflammation. He also diagnosed me with scapular winging. So I was wondering if you have any exercises or recommendations for that. I actually get a lot of questions relating to scapular winging, both over email and in person. And I think I'm going to do my best to try to respond to this without actually having, a diagram in front of me where I can show you the anatomical positioning, because I do think that's important. But, when I hear about scapular winging as a diagnosis, to me, it's very similar to what we hear with GERD, or glenohumeral internal rotation deficit. At the end of the day, it's a positional, it's a movement diagnosis, not a pathological diagnosis. It's a commentary on how people sit at a resting posture or how they move. And I'd argue that actually scapular winging, or dyskinesis is another term that's used in this world, is actually more of a garbage term than GERD. It's kind of like hearing shin splints. It doesn't tell you a whole lot about what's going on the lower leg, other than that someone has discomfort and you need to dig a little bit deeper. I'd argue that winging dyskinesis is worse than GERD because we can actually measure GERD with a goniometer. I'm not saying it's a raging problem for everyone and it's something you have to look deeper on, but at least we can quantify it. Dyskinesis is a little bit more of a subjective term, and I'll explain why now. But before I do, I think it's really, really important that we first talk about what the scapula is. And if you're, on your phone or you're sitting at a computer listening to this, I'd really encourage you just to go to Google Images and search for scapula and look at the positions, look at the nature of this bone. What you quickly realize is that it's not just a femur or a humerus. It's not a long bone that is very normal in its anatomical structure. It's got a bunch of different contours, a ton of different attachment points, because the scapula really is vitally important for a number of different reasons. And in reality, it actually interacts. It's got 17 different muscular attachments. So there are muscles that attach the shoulder blade to the humerus, the upper arm, that attach it to the rib cage, to the clavicle or the collarbone. It attaches directly to the thoracic spine. The latissimus dorsi as attachment points, and about 40% of the population, if you look at cadaveric studies, on the scapula, but it also attaches to the lumbar spine. There may be people whose lats actually attach on the superior aspect of their ilium, so it actually attaches on their pelvis or their hip bone. And then you have muscles on the scapula attached to the elbow and the lower arm via the biceps and the triceps. And then you have attachments with the cervical spine. So this one bone that kind of sits in the middle of everything from, kind of a transition from lower extremity to core to upper extremity movement. It's vitally, vitally important. And that's why it's a weird shaped muscle, and presumably why it can sit in a number of different places that may all be within normal limits, but things that aren't necessarily easily understood in a quick physical exam where something looks a little bit off. So when we actually look at how scapular positioning works, there's a great study from Ponton et al. Back in 2013. And this is a quote. They said, alterations in scapular positioning at rest and in movement called scapular dyskinesis are associated with various diseases of the shoulder, such as the impingement syndrome, rotator cuff tears, instabilities, and adhesive capsulitis. So no surprise that if your shoulder doesn't sit in a good position, you can wind up with all these different problems. What was really interesting about this study is they further said the inter-examiner reproducibility of the static clinical examination was considered from poor to satisfactory. The reproducibility of the static clinical examination with the radiographic examination was considered from poor to satisfactory. So what that means is we can all kind of say something looks off, but we all disagree on what off really looks like. Burkhart did a study in 2003. He's a great physician, has a ton of experience dealing with shoulder stuff. And he said that really anything greater than 1.5 centimeters or 5 degrees difference between sides qualifies as dyskinesis. So if your right shoulder's in a really funky position, we look at the left side as a comparison side. But in this population, sometimes asymmetry can be normal, and there are also situations where both sides might be in potentially a bad situation. So maybe we look a little bit further. Instead of just staring at resting posture, maybe the best play is actually to look at movement. So there's some research on scapular kinematics. Ludwig in 2019, his group said abnormal scapular or clavicular kinematics have been identified in populations with shoulder impingement, rotator cuff tendinopathy, rotator cuff tears, shoulder instability, and adhesive capsulitis. So same stuff as the static posture. The only problem, though, is that injuries and conditions are multifactorial. So it's not really as simple as saying bad scapular positioning causes this or bad scapular movement causes this. You can have horrible positioning of your shoulder blade, but then dynamically it actually moves really, really well. So you start in a bad position, but get into a good position when you go to throw. Or you might have a situation where you start in a great position, but you move poorly, but then you have amazing rotator cuff strength, so you can just make up for it. We know athletes are excellent compensators. So it's not uncommon to see people with completely pain-free shoulders who have scapular positioning that is off. It's not uncommon to see people, who have a lot of shoulder discomfort with what we would consider normal scapular positioning. So if you go back to that Ponton study, he actually defined that it's 26.7% of healthy subjects presented with scapular dyskinesis. So you can take dynamic testing, you can do strength tests, you can do all these different things, and you can kind of find something wrong with everyone. So what I always come back to is our assessments need to be descriptive and not predictive. That's the most important thing. Just because someone sits in a bad position doesn't necessarily mean they're going to get into a situation of pain, but it might give us a little bit of a clue for what exercises we need to select for them, or once we've selected those exercises, how we might coach it. So as an example, we may have a scapula that sits in anterior tilt. So that would be the classic. You see the inferior medial border. So the inside middle border on the back just kind of jumps right off the rib cage. You can put your hand right underneath it. That raging anterior tilt might be something where, you treat pec minor, you do some prone trap raises, you give them some posterior tilt, and they feel like $1,000,000. A lot of things get better when you give a scapula posterior tilt, particularly as you see people compensate when they have it, right? They may not be able to upwardly rotate, so they just shrug through everything, or instead of posteriorly tilting, they might use their lat to really aggressively pull the entire shoulder girdle into depression. You may also have a scapula that's too abducted. In other words, the the inside border of the scapula sits too far away from the spine. You may have a shoulder blade that sits too low in scapular depression, or even one that sits in a military posture where there's a lot of rhomboid dominance and the scaps are pinched all the way back to the spine. It's a very overlooked problem in baseball, what I would call a rhomboid dominant military posture that gets overlooked a lot when people look at shoulders. So historically, when we hear about scapular winging, we see like some kind of abduction. So the shoulder blade sits too far away from the spine or it's really tilted forward. Now, all of this is a really valid, kind of conversation point. But what I would add to all of this is that baseball players are different, right? A lot of these recommendations may be based on what we see in general population folks, post-op rotator cuff repairs and people in their 70s and 80s and things like that. Baseball players are very different because they generally don't have as much acquired kyphosis. So there's a normal curvature of the spine where, our thoracic spine is a little bit more kyphotic. Our lumbar spine is a little bit more lordotic. And that S shape creates a scenario where we handle compressive stress, really, really well when we load a spine. And really, at the end of the day, that neutral positioning gives rise to kind of the best opportunity for good rotational capacity. What we see in, some of those folks who sit at a computer for an entire career, or people who, just have poor posture and standing, bad training habits, or may have aged or had some kind of congenital disorder that drives more kyphosis, is they get really, really rounded over. And that drives scapular anterior tilt because what we have to realize is that the scapula sits on the rib cage, and that's controlled by the spine. And so this scapula sitting on the rib cage is a perfectly convex concave relationship, right? So if we deepen, the rounding of the thoracic spine, it's going to drive more scapular anterior tilt. But the opposite is actually true in baseball players, and really in tennis players, golfers. A lot of the high level rotational athletes we get actually spend way more time driving thoracic extension and rotation. So if you think about arching your upper back and like what you would do to initiate the layback phase of throwing or hitting a serve in tennis or something like that. And thoracic spine positioning is important because the spine and the rib cage tell the scapula where to go. If the thoracic spine is very, very extended, you lose that convex concave relationship between the rib cage and the scapula. And that can make somebody look like they have a really raging scapular dyskinesis or winging, when in reality, the scapula actually might sit in a good position, the scapula being the train and the rib cage being the tracks. If you flatten out a thoracic spine, it actually can make a scapular positioning look really poorly. And again, the scapula tells the humerus where to go. The humerus delivers the rest of the arm, which dictates, where the hand goes. And that governs a huge portion of athletic performance, whether you're trying to hit a big kick serve as a tennis player or, throw a cutter as a baseball pitcher. We really need thoracic mobility for a couple of reasons. In pitching, you need, adequate thoracic extension and rotation to allow for hip shoulder separation to occur and to allow the arm to settle into a good positioning during layback. And then certainly you need to go in the opposite direction to go and throw a glove side fastball. In hitting, the same thing is true. It gives you good hip shoulder separation to allow the arms to lag behind so that the bat can remain through the zone adequately. And then, last but not least, adequate thoracic flexion, the opposite direction in rotation, delivers the scapula and in turn the arm. So in hitting, that allows you to get to a ball that's thrown away from you when you're fooled and you need to go hit a change up the other way. Or it's something that, like I said, allows a pitcher to go and get the glove side. So I think what we have to recognize is that a lot of these scapular winging or dyskinesis diagnoses are really, really heavily rooted in what we see in general population shoulders. And we need to take a much more careful look when we're talking about making those comments in a throwing population, because every thrower presents a little bit differently, and someone who's very adducted and is sitting in a military posture might need something entirely different than someone who's anteriorly tilted, depressed, abducted. We have to really coach programs and prescribe exercises in a specific way relative to their posture. Now, with that said, At the end of the day, remember the relationship between posture and pain is very, very tricky to evaluate. The relationship between posture and performance is also a hard thing to evaluate. So some people will sit in bad positions, but get into good ones dynamically. So you really need to take a very broad perspective. So this is why when I hear scapular wing, the number one thing I would say is I'm going to do my own thorough evaluation of both static posture, of dynamic movements, and then I'm going to make sure that I coach meticulously and I solicit feedback from the athlete in front of me. Where do you feel this? If I'm doing a prone trap raise, I want you to feel it in your lower traps. I don't want you to feel it in your anterior shoulder. I don't want you to be blowing up your biceps tendon. If we're doing a serratus anterior activation drill, I want you to feel like the scapula is moving around the rib cage, and that we're actually getting to a good position instead, again, blowing up the anterior shoulder just to create that motion. So don't love it as a diagnosis. To me, scapular winging, scapular dyskinesis, they belong in a scrap heap with kind of what I would consider lazy diagnoses like GERD or shin splints or something along those lines. It's always a sign that we need to look a lot deeper on things. For our second question, we've got an inquiry from a strength and conditioning coach who works with younger baseball players. He said, I have a high school senior who worked his butt off this past offseason and was in the best shape of his life. I was talking with his parents at the game the other day, and they were saying that this is probably his worst pitching season ever. His velocity is down and command isn't good. Is that something that's pretty usual when kids get leaner and stronger? This is a great question, and I think it's something that gets really, really heavily overlooked. And for me, it's kind of a pain point. I hear this a lot in high school kids. It's just that pitching is something that demands absolute precision to be successful. Certainly at the highest levels, but definitely at younger levels as well. And we see a lot of erratic performances in high school baseball players. Particularly as they change their bodies dramatically. You put on 20 pounds, get leaner, grow 6 inches in an off season, and your delivery can change dramatically based on some of these kind of anthropometric characteristics that get overlooked. So I'm a really big believer in not putting too much pressure on high school kids to really repeat their delivery. But in a situation like this, the first question I'm asking, has it been consistently bad, or have there been flashes of brilliance and then it goes down the tubes? Because the solution on these is going to be very different depending on the answer to that question. So if it's been consistently bad, my course of action is I'm going to ask about, like, hey, is this a kid who's a newborn horse? Like, did he actually go through some pretty substantial changes to his overall physique, to the point that his center of mass moved up further away from his base of support really quickly as he went through a growth spurt? Or was he a kid who's been 6'1" the entire time and he just put 20 pounds on? And what I would really encourage you guys to do is check out an article I wrote. It's called Are Pitching Mechanics Really That Repeatable? It came out several years ago. I wrote it after kind of going through the process with Tyler Beatty as our first round pick all the way back in 2011, and really seeing Ty's development and how people just held him to like an absolutely unrealistic standard of perfectly repeated mechanics as a high school senior. It was pretty crazy to me. What you realize very quickly is even the best throwers on the planet can have wild deviations and metrics, both in terms of spin metrics, command stuff, things like that, and they have to constantly rein those things in. And that's with the help of great coaches and insane amounts of data. High school kids don't have these things at their fingertips. In many cases, they're pitching outside in the Northeast in April when it's 30 degrees out and they can't feel the baseball. So there are a lot more erratic performances. But again, we're going to stick with this kid has obviously struggled with both velocity and command. Whatever he did this winter might have changed his physique, but didn't actually make him better at baseball. The first thing I would look at is body weight reductions. Did he get a lot leaner? Was this a kid who had maybe a bad body that dropped 25 pounds of body fat and all of a sudden he's much, much lighter? We know body weight does predict pitching velocity. There's good weight and there's bad weight, but sometimes we see people who lose weight too quickly, and it can definitely impact their ability to throw the baseball hard. Also strength loss, or power loss, probably more specifically. Sometimes we see athletes that, do a bunch of aerobic work or just lots and lots of high rep stuff. And, they aren't nearly as well conditioned for an explosive activity like pitching. So, how he changed his physique would be, equally important for me of a question. Did he go out and run 40 miles a week, or was it something that happened with a lot of strength training, med ball work, really high quality, athleticism oriented training? And I think as the season goes on, many guys just don't get enough quality weight room work to maintain the strength and power. So if we see someone who sees a drift over the course of a season, that's another question. Obviously, you always want to rule out any kind of underlying injury that could be in place. Sounds like he's been healthy and he's in the best shape of his life. So that one's not something we look at. But in many cases, you will have people that just aren't reporting that they are actually hurt. But I think the one that my brain goes to right away is an actual loss of mobility, or someone who has changed so dramatically that they've made a pretty substantial adjustment to their delivery instead of just letting kind of like the newfound body weight and strength and power kind of take care of itself. I do think there's a cost to all training. Some training enhances what you're trying to do. It has a direct carryover. There's a transference to some level of sport participation, and then there are kinds of trainings that interfere. So, as an example, if we have a really wide infrasternal angle athlete who's already a 550-pound deadlifter, moves huge weights in the squat rack, loves to bench, all that stuff, and I spend an off season, basically trying like crazy to put 50 pounds more on this deadlift. And meanwhile, he loses a bunch of rotational capacity, his hips, his thoracic spine, and his forearm with pronation and supination. I didn't necessarily create a favorable adaptation for him to go, play a sport where manipulating a 5-ounce baseball is what makes him money. Conversely, if I take a kid who, as weak as, can be at 135, pounds soaking wet, and I put 20 pounds on him and he gets a bunch stronger, chances are the carryover is going to be better. So, the transference is going to obviously be dictated by the training status of the individual. One of the quick things you can look at is like measure this kid's range of motion on table, shoulder, internal and external rotation, thoracic spine mobility, hip mobility, whatever it is, and then go, have him grab 225 and go for a walk, do some farmer's walks, do some heavy deadlifts, do something, and then come back and remeasure him. And if he's lost a noteworthy amount of range of motion from that loading, chances are that a lot of the strength work is actually interfering with his ability to really effectively rotate in a high level delivery. That happens quite a bit. I'd say more often than not, though, at the younger ages, there has been some, substantial change to the delivery that's putting them into some bad positions. They don't maladapt to training the same way that a 34-year-old who puts on 30 pounds in the weight room might maladapt. So, looking at how the mobility has changed, looking at how the delivery has changed is probably where you're going to go first with this. The only thing I would add is sometimes we see an athlete who's changed physically dramatically. They've also become the senior, and the assumption is they're going to throw hard, so they jump right in, and there's an excessive amount of workload. Maybe a coach has pushed them a lot, and they're just a ton of fatigue. And we know that fatigue masks fitness. So, if you're dragging and the velocity is down, short-term reduction in throwing volume is often the quickest path to getting velocity back. Particularly pitchers who are throwing more innings than ever before. Maybe it's a guy that throws an easy flat ground instead of a bullpen between starts, or maybe they alternate higher pitch count outings with short outings. Whenever I hear about a high school pitcher who has an exceptionally high pitch count of more than 105 pitches, something like that, I usually tell them to take the next one a little bit lighter of 80 pitches, something like that. Something about high school kids that, get into trouble when they go over 100 pitches in back-to-back outings. So when I hear about a kid whose velocity is well down, the first thing I'm trying to do is eliminate fatigue as a cause. What we know about younger guys is they do tend to recharge pretty quickly. So tell a guy, take 3 days off completely from throwing and training. Eat all the good foods you possibly can in sight, fruit, vegetable, plenty of good protein, not a lot of junk, but healthy stuff in adequate quantities. Get to bed early, bust out the Mark Pro, maybe do some contrast stuff, whatever it is that you like from a recovery standpoint. And then see where you're at. See if your arm feels absolutely electric when you come back from that, because that's usually a pretty good indicator of whether you've got, accumulated fatigue that are interfering things. But typically that works a lot better in college arms that, are a little bit further along. More often than not in this high school crowd, you've lost some mobility, or the delivery has just drifted to a bad position. And fortunately, the delivery stuff is generally an easier fix in that population, particularly if they've had it in the past. You show them some video, you change the drill work up a little bit, you maybe set their sights a little bit different and give them some external focus cues. And things really do kind of come around quickly. But you hate to see a high school kid go through an off season, put in tons and tons of work, and then not have it transfer over. So I would definitely, look for some of the quick fixes, whether it's removing fatigue, adjusting the delivery, changing the pregame warm up, something along those lines is probably where the solution really lies. For our last question, we've got a quick one. What are your thoughts on toe spacers? And briefly, I love them. Actually become a really big fan of them over the last couple of years, and they've helped me a ton myself when I'm on my feet for long hours coaching on hard floors. So the first question I would ask you is, if you stand up and you're in bare feet, can you lift your big toe up independent of your other toes? And then further, can you keep your big toe on the ground and then lift up your other four toes while it stays put? You'd be shocked at how much variance there is in athletes' abilities to do this. You see a lot of athletes who have, very poor big toe mobility. They always have pain on doing reverse lunges, things like that. But then you go and you compare that to a mixed martial artist, gymnasts, people who have spent their entire life, training in barefoot disciplines, beach volleyball players, things like that. They always tend to have much more dexterity in their feet. Soccer players are notorious for having really good dexterity just because they kind of spend their life in kangaroo leather shoes that really kind of conform to their feet as opposed to feet that are just stuck in really restrictive shoes. So when I look at, kind of how the feet work, I think it's important to understand the gait cycle. So if you think about, you take a step on your right foot, say, the right side of your calcaneus, your heel bone, sets down and it kicks off the process of subtalar joint pronation. So what pronation is, it's a flattening of the foot, as we all know, but that's an adjustment, to accommodate deceleration, to give us the ability to adjust to unstable terrain, all that. So pronation basically slows us down. And then what happens at the end of pronation is we need to switch back to supination. And what happens is that creates the arch that we all know. And that rigidity in the foot creates a really good platform from which a lot of the intrinsic muscles of the lower leg can work. They can propel us off. So you never really want to propel off of a pronated foot, and you never want to decelerate on a supinated foot. Supinated feet are great for propulsion, but not necessarily slowing us down. Pronated feet are good for slowing us down, but not necessarily propelling us. But what's really interesting is if you look at some of the absolute best athletes in the world, you look at NBA superstars that, can come down from a rebound attempt and just spring right back up. They're super elastic. You look at high level tennis players that change direction, NFL running backs that can stop on a dime. A lot of these athletes have bunions. If you go and you look at LeBron James's feet, go to Google Images and just search for it, you'll see James has kind of like a middle toe that's kicked up, and he has some kind of bunion presentations on his feet. Some of the best athletes in the world actually have these ugly feet, and the reason is very simple. They kind of live at the absolute edge of pronation, so they're so heavily geared towards being on the inside of that foot. It's an advantage because it allows them to not be stuck in deceleration mode too long. It allows them to make deceleration happen quickly and turn right back over to a little bit more of a supinated foot to push off. So it creates some of these structural adaptations that kind of creates a foot that's bunched up, where medially they develop that bunion type presentation, and then the toes get closely pushed together. And it's exacerbated by having, footwear that can be really, really restrictive. So I think some of these athletes are excellent fits, for toe spacers, just to kind of open things up and recoup a little bit of the lost range of motion. Full disclosure, I have consulted for New Balance since 2011, and one of the reasons is that their cleats are heavily geared towards comfort, and they do a lot of focus groups and product testing to make sure that the comfort is really, really good. In the baseball world, and in Major League Baseball, I play 162 games plus spring training plus postseason. So if you're going to be wearing something for 6 to 8 hours a day, it better be really, really comfortable. And we've had a lot of success switching players to New Balance cleats with near instant results, and some of the best players on the planet who are in their shoes out as position players. And it frankly may be due to large part to the fact that they have more options in a wide toe box than other brands. That's something that some players do really well with wide cleats, or just a normal cleat that generally has a little bit more space there versus other brands that are a little narrower down in the toe box. So back to toe spacers, they're great for unlocking just a bit of motion in the foot to kind of play for the tie after you've been in footwear a ton throughout the day. I personally wear them a bit at night while working on the computer, throw them on for 30 to 60 minutes while you're doing something else. And I've even put them on and slept in them without an issue. You wake up in the middle of the night, you just take them off and, throw them on the nightstand to recoup in the morning and do it all over again the next day. I'm a big believer, in just looking at anatomy to drive a lot of our decisions. And if you look at some of Thomas Meyer's work, a lot of the Stecco research on kind of how the fascial system is designed, your feet, your hands, and your head are where a lot of these prominent fascial lines begin or end. So it makes sense to free them up, to facilitate whole body mobility. honestly, I can't say I've ever seen any negative or side effects to wearing toe spacers, particularly because they're super cheap. You can try them out, see if they're a good fit, and then kind of move on from there. But I've seen some good results for them. One very interesting anecdotal story. We have an athlete who we saw who had, in his teenage years, he had bilateral patellar dislocations. Really, really tall athlete, lots of range of motion limitations. But he was also an athlete who was a cancer survivor. He had had chemotherapy, and one of the big concerns with a lot of chemotherapy drugs is challenges with peripheral nerves. So, sensations in the feet and the hands in some of these athletes or patients, I should say. And that was something that was always very concerning for him. And he never felt like he had a lot of the dexterity back in his feet following his chemotherapy treatments. And then obviously having multiple knee issues on top of that, he kind of lost his lower extremity. And what was fascinating is we tried some toe spacers out for him, and he came back in a few days later feeling like he had seen a ghost. It like completely changed his perception on how he interacted with the ground. It was an absolute difference maker for him, and it's been something that's become part of his routine moving forward, and really feels like it's unlocked more mobility further up the chain. So just an eye-opening sample size of one story that was really cool for me. It was a little bit of a Hail Mary, but it worked out really, really well, and it makes sense. Big dude, significant injury history, pharmacological interventions that may have some pronounced impact. So we just add a little bit of motion distally, and sure enough, it freed up some better movement proximally. So my feeling is check them out, try them out. They're super cheap. Roll them out there. I'll throw a link in the show notes on the particular brand I like, and you can try them out and see how it goes.